Hello, good afternoon, good morning, or good evening, where depends where you're watching us from. We apologize, we had some sound problems. So today we are again joined by Dr. Mike Ryan and Dr. Maria Van Kerkhove. So if you have questions and watching us on Twitter, please use the hashtag AskWHO to send us your questions. If you're watching on other platforms, we will be monitoring your comment section and pass your questions to them. This week started on a sad note. We are marking a tragic milestone of 5 million people who lost lives to COVID-19 that we know of. And we're seeing cases globally on rise again. So Mike, Maria, maybe we can start with reflection on this milestone and also on the epidemiological situation globally.
Yeah, Alex, this is quite a tragic, another quite tragic milestone that we reached in this pandemic of more than 5 million people dying from COVID-19. And we know that this certainly is an underestimate of the true number of people who have died. Some estimates are 3 times, maybe even more, that have actually died from this disease. But by far, the entire world has been impacted by this virus. And there are others who have died because they haven't been able to receive the care that they need because health systems have been overwhelmed because of this pandemic. So I don't think we know yet, we certainly don't know yet the true toll that this pandemic has taken. And I think we also haven't really understood or even begun to mourn the loss of these 5 million people, these lives, these livelihoods, parents, children, aunts, uncles, friends. Each person is a person and has a family. Each person has a story, and I don't think we can ever become numb to these numbers. I don't think we should ever become numb to these numbers. And unfortunately, as you say, cases are on the rise again. It's been 2 weeks at the global level where we're starting to see cases increase again. But we're also seeing deaths increase again. So while we have a huge number of vaccines that have been distributed worldwide, more than 7 billion doses, those people who have received the vaccine are being protected against severe disease and death. But those who haven't had access to the vaccine are left vulnerable to getting severe disease and dying. And that's what we're seeing. We're seeing cases among those who are not protected. We are seeing deaths among those who are not protected. And more than 50,000 people a week are dying from COVID-19. These are deaths that can be prevented and should be prevented. And I think, we need to find ways to, honor those who have died. And every single one of us has a role to play in bringing this pandemic closer to the end point. And I think that's what we need to remain focused on. As we can't have another tragic milestone and then just mark it with a tragic milestone and move on to the next. We have to make some changes. And if we don't do this now, when will we? So I think everyone needs to kind of reflect on that. But yes, at a global level, we're seeing increases. It's largely driven by increases in cases in Europe. More than 60% of cases in the last 7 days have been across Europe, which is a huge region, all the way from the east to the west. But there are also a lot of deaths that are happening in Europe as well, where there is ample vaccines on average, across the continent. But we are seeing increases in the Americas, increases in the Western Pacific in cases. We're seeing increases in deaths in Southeast Asia and also in the Western Pacific. Other regions are reporting declines. But when you look at a global level, you look at a regional level, it masks the variability that we see in transmission. And transmission remains driven by the factors that we've talked about many, many times. A highly susceptible population, because they don't have access to the vaccine. They haven't had this powerful life-saving tool. We have variants that have increased transmissibility. These variants are circulating in the context of increasing social mixing and social mobility. And this is in the context of the inappropriate use of public health and social measures, not lockdown, but simple individual level measures that we know reduce the spread of this virus and save lives. And in some cases, the complete lifting of public health and social measures. And lastly, in a whole context of huge amounts of misinformation, disinformation, conflicting messages, and further politicization. So all of these factors put us globally in a very dangerous situation, but it can be turned around. And I know we'll talk more about how that can be turned around, but we do need to reflect on the milestone that we have now and work as hard as we possibly can to make sure that that number does not keep increasing.
Thank you, Maria. Mike, I'm sure you have thoughts to share on the moment where we are now in the pandemic.
Yeah, and we're also very close to that 250 million cases globally, and that number is stuck stubbornly at sort of 2% of people, of confirmed cases reported, but we have about 2% in terms of deaths reported. Maria spoke there about Europe. I mean, it is quite concerning that, nearly 3/4 of the cases in the last week reported on the planet were from the European region, and nearly 2/3 I think, of the global deaths. So I think this is a real concern, and it's a worry because, as Maria did say correctly, the vaccination rates are probably as high in Europe as they are anywhere in the world. So people are probably understandably asking themselves the question, well, how is this? We've got high vaccination rates and our health systems have recovered, and yet here we are with huge increase in cases and huge increase in deaths. And again, it's going back to the basics that we've been speaking about now for 2 years. We have, understandably, in many situations, economies have opened up, societies have opened up. We've back to school, back to university, back to work. Entertainment has opened up, mass gatherings have opened up, nightclubs have opened up, bars have opened up all across the region. And at the very same time that people are going back inside, temperatures have dropped, it's raining, it's freezing here in Geneva today. So, it's getting dark earlier, and it's these small factors, the fact that it gets dark earlier, the fact that it's colder, you don't sit outside anymore, you tend to go inside. And all you need to have is 10 or 15 or 20% more people make the choice to go inside rather than stay outside. And then you add to that the fact that there are still a significant number of people with underlying conditions or vulnerabilities who are still not vaccinated. And then when the transmission picks up, particularly amongst younger people, they again may not be greatly affected by the infection, although some can be. But then the danger is a vulnerable person is somewhere in that transmission chain. And another thing to remember, I think, is vaccines are really good, and these vaccines are remarkable. I mean, I don't know if we've ever had first-generation vaccines that have been as effective as these vaccines have been. But vaccines aren't perfect. They don't provide absolute protection. And as potentially immunity decreases over time, and as people are exposed again to the virus, there's always an opportunity for a breakthrough infection. So even older persons who've been had their 2 vaccines, or even those older persons, for example, or people with underlying conditions who've received a 3rd shot or a 3rd primary dose, I think we're going to have to be careful. And again, we're back to saying, yes, you're vaccinated, but you need to still wear your mask. Let that bus pass by if it's packed at rush hour. You don't go into that crowded bar. If you're someone with underlying conditions, if you're someone with a vulnerability to this virus, yes, the vaccine will afford you a huge amount of protection, but that protection is not perfect. And if you're not vaccinated, please get vaccinated. For those of you lucky enough to live in a country where vaccines are available, please go out and get vaccinated. And again, Maria spoke to the fact that there are many countries still where even health workers have not had access to vaccines, which again speaks to the terrible inequity we still have.
Thank you, Mike. Here is a question exactly about vaccine equity coming from Errol Kansek, watching us on Facebook. The new strategy outlines a plan for achieving WHO's targets to vaccinate 40% of the population of every country by the end of this year, and 70% by mid-2022. So his question is, what if we do not reach these targets?
Well, the way we're going, unless we, really speed up, we probably, we're not really looking like we're on track. I think there's over 100 countries that are at risk of not reaching that target by the end of this year. The vast majority of them, of that just over 102 countries that we estimate may not reach the target, 4 out of 5 of those, it's a supply issue. For some countries, for a small number of countries, they have a supply issue, and they also have a capacity issue for delivery, and we're working very, very hard with those countries, with Gavi, with UNICEF, with other UN partners and NGOs and others, with those countries. And they're very often the countries that are in conflict and fragility, that need extra help and support in terms of logistics and cold chain, and sometimes with vaccine hesitancy. But the vast majority of those 100 countries, the 102 countries that we estimate may struggle to reach the 40% target, the vast majority of the reason for that is a lack of vaccine supply to those countries.
Thank you, Mike.
Please.
Can I just say something? I mean, I think Mike is right. I mean, we're not on target to reach that, but it can be turned around. That's the whole point, is that we are having issues about getting vaccines to the right people in the right countries. There are ample vaccines right now. 7 billion doses of vaccines have been administered to date. If those vaccines had been administered differently, along the strategic plan of what WHO had outlined, 10% of populations, all populations in all countries, by the end of, was it June? September, thank you. 40% by the end of this year, 70% by mid-2022. If we had used those vaccines differently, we would be well on target for this 40% of all populations, but we're not, because the vaccines are held up in certain countries. And now we have the issue of boosters. We have the issues of many countries offering boosters to people who are well protected. I'm not talking about a third primary dose for people who are immunocompromised that need that third dose to make sure that they're fully protected. We're talking about adding boosters onto people who are well protected. That is having an impact on supply. That is having an impact on the fact that those vaccines, those vials, are actually sitting in countries where they are not most needed. And I know that's hard to say because a lot of countries, they want to protect their populations, and we understand that, but that's at the expense of others.
But also, I think the way the contracting works, that, there are funds to go buy these vaccines, and what we've been asking for is that countries that have an oversupply have more contracts than they actually need, even to do their boosters. Yes. And that's the reality. Yes. There's enough vaccines to be able to do both strategies. The problem is so many of the contracts are locked up in a way that the COVAX initiative can't get access to those contractual terms. We need people to step out of the way. I mean, of all the vaccines that have been pledged in the last 6-8 months by countries, by developed countries, only 15% of those vaccines have actually been delivered. 15% of all these pledged donations. I've said it before, you can't stick pledges in people's arms. You need vaccines. We have this, I think sometimes I see it sometimes in the humanitarian scene, and I hope the pledges that are made in Glasgow this week in COP26 will be kept. We tend to have this syndrome of pledges. Everyone stands up and they pledge. It's like a New Year's resolution. I promise not to, or I promise to, and a few days later it's forgotten. But when you make a pledge like this, when you pledge to give life-saving vaccine to another country, and countries begin to plan to be able to use that vaccine, that's more than a pledge, that's a commitment. And there's a responsibility, that's a promise. And it can't be just seen as something can be whittled away after. So we need countries to make good on the pledges that they've made to deliver donated vaccines. We need the manufacturers to prioritize the contracts for these countries that badly need to get to this 40%. And we need countries who have contracts with these companies that aren't absolutely essential right now. They have enough supply to supply their own needs, and they could relinquish some of these contractual places in the queue to other countries. So there's lots that can be done, and I agree with Maria. if you put enough pressure on each of those points, and you can change the game, and the supply is increasing, there's no question. The supply is starting to increase, and congratulations to the COVAX partners in this, and particularly to our colleagues in UNICEF and Gavi and others who worked really, really hard on this. This is not just a WHO objective, and you said about the WHO objective is 40%. It's not just a WHO, it's a collective objective of all the agencies who've been working on this so hard. And if we can get to that 40% in effect, and we have to make sure it's the right 40% too. I mean, 40% needs to include the health workers, the vulnerable, the older persons. Then we can really bring back a much more level playing field, and then accelerate in 2022 towards the 70% by the middle of next year. All of that is possible. All of that is possible. If we can now push on getting the supplies over the next 2 months. And our projections are that that can happen, but it requires each and every one of those opportunities to be taken. The contracts, the pledges, and we need both the private sector, the manufacturers, and governments to work together with partners in COVAX and in the AFAT, the African initiative as well, in order to provide vaccines.
Thank you so much, Mike. There are quite a few follow-up questions on this subject, and the first one is from Abdullah Ben Adam. You were talking about that we have many vaccines and there are great tools that we can use. So he's actually asking, why are there so many vaccines? This pandemic is one. Why scientists don't unify behind one vaccine?
That's a good question. What can happen over time is that you get some vaccines that clearly show to be more effective than another vaccine. You can often end up with one or two. I mean, historically, we've been lucky to get any vaccines in some cases against certain diseases. It's taken decades to develop vaccines, and there's been relatively little interest in developing vaccines at certain times. Many manufacturers and governments in particular, there used to be a very large state-based vaccine. Actually, vaccine manufacture was mainly run by governments and states, and many countries had their own capacity to produce vaccines. Over time, with the cost of vaccine development and production, and with the liability issues and many other issues, there was a consolidation. We've seen that in lots of markets, a consolidation of the market, so you end up with a very small number of companies producing most of the vaccines in the world, and that caused a problem. But then we saw the emergence of companies in the developing world came on stream and really started to produce high volumes of vaccine in Indonesia and in India. And if you look at polio vaccines around the world now, the vast majority of people who get polio vaccinated are getting vaccinated with vaccines from the south. And that allowed many manufacturers in the developing world to enter the market. But in the case of COVID, it's remarkable that so many of the vaccines that were actually trialed worked. I don't think anyone honestly expected so many of the vaccines. So it was great to see not only the big pharma but the smaller biotech companies get involved in developing that. And a lot of these vaccines are very often developed. A lot of the first products, even drugs, are very often developed by smaller biotech companies or universities, public-private partnerships. And they're the ones that drive the innovation very often. And then the bigger pharma companies can come in and underwrite the expansion and the production. It's a bit like making movies. Sometimes it's a small independent producer produces the interesting stuff, but the distribution is with the big companies. So you need a partnership between a smaller company and a big company. And we've seen that with some of the developments here. So we've seen all of that happen. And we're lucky to have as many vaccines as we do have. The problem is when you put all that production together, there's enough to go around. The problem is it's not being shared equally amongst those who really need it, and that's the problem we have to fix. We may settle down in the long run, and will depend in terms of if we end up with regular vaccination against SARS-CoV-2. It remains to be seen. It may be that there are some products that will be considered superior to others, but right now most of the products, or all of the products that have been approved, and there are more coming through, some very interesting concepts, nasal vaccines, which are very interesting because you might be able to develop immunity in your nose, which could really help to interrupt transmission, not just infection. And that could be a game changer. So there's some miles to go in terms of there's further innovation that can happen in this space. So I'm pleased we have as many as we have. I know it's a little confusing for people out there, but we'd be in a lot more trouble than we are right now if we didn't have so many vaccines available.
Can I comment on that as well? Because if you remember, more than a year ago, we were sitting having a discussion about the fact that there was no guarantee that we would have any vaccines at all. And the fact that there are so many safe and effective vaccines is really a triumph of science, and it's a triumph of collaboration. What we were saying back then, if we can remember, if we can recall, the more vaccines that are in production, the more opportunities we have to succeed. And that's still true. There's still, as Mike just said, there's a lot of vaccines that are still in production with different platforms, different delivery systems that need to be supported in terms of their development. The vaccines for COVID-19, people think began when we first learned of this cluster. But in fact, the basis for the development of these vaccines began years before that with, many different groups. And through the R&D blueprint for epidemics, focusing on high threat priority pathogens. One of those pathogens was MERS coronavirus, another highly transmissible, not as transmissible as SARS-CoV-2, highly lethal coronavirus that was first identified in the Middle East. And there was work that was done developing a MERS coronavirus vaccine. There was work done even before that on mRNA technology. And that was the basis for which we were able to have so many rapidly develop safe and effective vaccines for COVID-19 once we had the sequence of SARS-CoV-2. And I think that's really important because there was no guarantee that we were actually going to have a vaccine that was safe and effective, and certainly no guarantee that we would have so many that are so strongly protective against severe disease and death. And I think relating to your question before, what we're seeing in the data now of people who have received their full course, the 2 doses, those who have been fortunate to receive those full 2 doses, we're seeing a very strong, long-lasting protection against hospitalization and against death, including against the Delta variant. That's really critical. Well, we will see over time how long that protection lasts, and of course it remains to be seen, but that's very, very good news. And that's why we're also recommending that we focus on getting the first and second dose to those who are most at risk in all countries before we start giving additional doses to people who are well protected. And I think that, epidemiologically, not only morally makes sense, but epidemiologically that makes sense too, because if we can reduce the death, if we can reduce the hospitalization, we will reduce the burden on healthcare systems, on our health workers, our frontline workers that are there. And then we will start to see more mild cases, which don't need as much attention in hospital systems. We have to continue to worry about long COVID and the long-term effects of infection from SARS-CoV-2, but at least we can start to manage and get systems online. But again, I have to come in and say, it's vaccines and not vaccines only. We have to continue to increase vaccination around the world, but we also need to take steps to limit the spread, because if we only do one of those, then we still have the possibility of further virus evolution and more mutations, which could potentially render our countermeasures, including vaccines, ineffective. And we don't want to get in a situation like that. So it's 2 sides of the same coin. But technology, investment in these platforms is a very wise investment. And we hope that that will continue, not just for the coronaviruses, but think of the other pathogens that are out there as well. Not to scare anybody, and we don't need to talk about those, but there's a lot of investment in other areas of work as well, because that needs to continue, because we could be in situations in the future where we need other types of vaccines. So a big shout out and thanks to all of the collaborators who are out there that are working so hard on this and really to keep it up.
Thank you so much, Maria. Mike, you mentioned, for example, polio vaccine that's now being produced across the south of the planet. Here's a question from Justice watching us on LinkedIn, but there's quite a few similar questions about production. So he is asking, why is it not possible to agree and produce vaccines in various continents and make it easily accessible to every country, especially in the low economic countries? And there was also another question about sharing scientific knowledge and know-how among countries.
No, it's a very good question, and as I said previously, there are some superb vaccine production development facilities in the south. When you look at the Serum Institute of India, it's an outstanding setup and facility there. So there is no real technological barrier to that. Number one, it's an expensive undertaking. Producing vaccines requires very high standards of good manufacturing practice, very high safety standards, hugely complex regulatory standards as well. So it's not just having companies who can produce vaccines, it's having the regulatory and state support there to oversee that, to make sure those vaccines are safe, to make sure you have the trained staff. There's an infrastructure that goes with vaccine production, and it's not just about having a plant. You have to be able to develop a vaccine, test that vaccine, do trials, then you've got to be able to scale up the production, you've got to scale that production with really high quality manufacturing practice, and then you've got to be able to distribute that vaccine within your own country and globally, and create markets for that. So it's not just about purely the technology. There's a whole industry that goes with that, and many countries have really developing countries have really engaged over the last number of years and have become very big vaccine producers. I think the difficulty arises when you have new platforms, for example, like the new mRNA platforms. Everyone will know what they are now. And then there are these vectored vaccines. So vaccine technology is moving on. So the old way we used to produce vaccines was we used to have attenuated or killed vaccines. We basically have killed viruses, or we'd develop a weakened strain of the virus and then inject that. So it was a relatively straightforward, simple technology. Even influenza vaccines or flu vaccines are still produced in eggs in most parts of the world. I mean, it's 50-year-old technology. So the technology base was available, it was out there. Countries, there wasn't a barrier to getting involved in that. But there are some barriers, technological barriers, intellectual property barriers, in getting involved in some of this newer production. And therefore you have to be able to access the technology and the scale up for that technology. And I think that's where we've been really asking countries and companies who have that technology to share that technology, because this is a global crisis. But it takes time. Even if that technology is shared, it takes time to bring that online, bring that on stream, and ensure that it is very high quality. We were saying before, we've done lots of work over the last number of years on Ebola vaccines. We had the target product profiles for 9 disease plus disease X. We've been working very well with organizations like CEPI, which is the Coalition for Epidemic Preparedness Innovations, and BARDA in the US, and many others. And there's been a huge amount of investment in developing candidate vaccines for these really severe emerging diseases. And that's gone really well. And we are getting more and more vaccines coming online. And it's relatively easy to produce enough vaccines, for example, in Ebola or in Marburg disease, because the outbreaks tend to be reasonably small. The number of people you need to vaccinate is relatively limited. It's in the thousands or hundreds of thousands. When you have a pandemic, you've got to vaccinate 7.5 billion people. So having the vaccine is not good enough. You have to be able to go to scale. And that's the problem. The problem we've had is not the vaccine development. The problem is our ability to scale up the production. We just have not had enough producers, and we were not in a position, we weren't ready to be able to transfer that technology or scale up that technology. There are companies like AstraZeneca who have transferred technology and have developed production capacities, or transferred or contracted production capacities in other countries, and that's helped to scale things up. But we just have not got to the scale of production needed. And then when we have got to the scale of production needed, we haven't been able to share those vaccines equitably. But I do think many countries in the South are justifiably annoyed. And this has become a real issue for them, because this is about their national security now. Are they going to sit there for the next pandemic and wait for the crumbs to fall off the table? Or has the issue of being able to produce your own vaccine become a national, not just a health issue, but a national security issue? That this is a production capacity that countries need to have. And it's not, to be honest with you, every country doesn't need the capacity to produce vaccines at high volumes. As I said, it's a complex technology, it's expensive. It would be much better if we could all trust in a system that could produce vaccines for everybody, because there are economies of scale. Producing vaccines at scale is very often better done in large plants that can produce at scale and scale up quickly. The problem is, if I'm sitting at the end of the line waiting for my vaccine, and the production of that vaccine is in a developed country, and I stand in that line and nobody ever gives me vaccine, then it doesn't matter what the scale of production is, because I'm never in the line. I'm always at the back of the line. So I really don't blame many developing countries for being cynical right now about these promises about vaccine sharing and equity and technology transfer. And I think a lot of developing countries are really saying it's time that we had our own capacities, because this is now very much a national security issue for these countries.
You had a second part of the question, I think, around sharing of scientific knowledge.
Yep.
And sharing, I mean, I think it was primarily asked about sharing of the technology to build those vaccines, but I do want to say in this pandemic, we have had unprecedented sharing of scientific knowledge across the globe, across all technical areas. And if there's one thing that we could see real unity on and real solidarity, it's in the scientific community, in every aspect of this pandemic, in terms of how, transmission, in terms of clinical management, in terms of, animal-human interface. I mean, you pick a topic. There is a difference, in what I think the question was asking about sharing that technology and know how to produce the vaccine. But on a daily basis, we as WHO, we convene scientists from around the world to talk about many different topics related to this pandemic, how it's evolving, where it is going in terms of future scenarios of this pandemic itself, the variants, what does it mean with the emergence of these variants and future vaccine production, future vaccine composition. What does it mean in terms of our guidance? It's a daily thing that we do. And we, have worked with people in all countries. I mean, it's pretty amazing the ability to have been able to do that in this pandemic with the expansion of, the different platforms of Zoom and Teams and all of the different platforms that people use to connect. That has not been the barrier. When you talk to a scientist and they want to share. You talk to a clinician in a country that is seeing those initial cases, they want to communicate outwards to others who had similar experience with a pathogen that may have been like this new novel pathogen. They want to connect and communicate and see, what are you seeing? How can we help? That's happened at an unprecedented scale, and it's still happening to this day. We come into problems when it relates to, things, related to the production of these vaccines, but that's also changing, and that can continue to change to build up that production. But I did just want to say that sharing of scientific knowledge in this pandemic on the whole has been incredible.
Thank you very much, Maria. Here is a question from Jameson Babuk, watching us on Facebook. I think you can take this one. What variant is responsible for the current infections and deaths in Europe, as you highlighted that there is a big increase? And he also has a second question. Are you following the vaccinated people to find out their immune status against the variant circulating?
So these are two good questions from Jameson. So the Delta variant is dominant worldwide. Among all of the sequences that are shared by countries on platforms like GISAID, by far, almost all of them are now Delta. More than 90%, more than 95, I think more than 98% of all sequences are now Delta. So that is predominantly circulating worldwide. And this variant is by far the most transmissible variant that we have seen. Now, having said that, Delta is also evolving. And so the more the virus spreads, the more opportunities the virus has to change. And we are tracking more than 30 sublineages of Delta, which mean Delta plus additional mutations. We're not using this phrase Delta plus because that doesn't really mean anything, but we're looking at Delta with additional mutations. If any of those become variants of interest or variants of concern, we will also name them as well. But the Delta will not be the last variant you will hear us talking about. The question is, will the virus become more fit, more transmissible? There's some suggestion that one of the subvariants is a little bit more transmissible, but we have very limited data right now on this. There are very few sequences of this AY4.2 sublineage of Delta, so we need to be cautious about how much we can say about it because we don't have all the information yet. But there are a number of studies that are underway, and we are working with many partners to assess what do we know, what studies need to be done, how quickly can those studies be done, in terms of transmissibility, severity, any impact on our diagnostics, therapeutics, and vaccines. So all of that is underway, and that will continue. That's a process that we have in place. The second question was?
The second question was
Vac-
following vaccinated people.
We are, I mean, there are studies that are ongoing that are following individuals who have been vaccinated. These are real-world studies looking at how effective the vaccine in terms of protection against severe disease, meaning hospitalization and death, but also against infection. And so there are many studies that are underway, and a lot of these are being published now. And we have several groups that are tracking these studies and evaluating them as reports when they are provided to us, even before they become preprints. You know, once they become preprints, and of course, once they're published. But I do want to reiterate what I said about protection against severe disease and death. We're seeing a very strong response, this horizontal response, steady level protection against severe disease and death. There is some slight variation depending on the vaccine, but very strong against severe disease and death. We do see some waning protection against infection, but the vaccines were not designed to prevent against infection or transmission. However, they do have a positive effect on that as well. So yes, the long-winded answer to that is yes, and we will continue to track that because it's a really important measurement to look at, because this will inform our response going forward. We're also looking at people who have been infected with the virus itself. So people who haven't had vaccine, but who have a infection-induced immunity, and looking at their response of antibody levels over time. This is also something that's really critical to look at, because not all, many countries have not had access to the vaccine yet. And so what we're looking at is we're tracking those individuals over time in these seroprevalence studies, and looking at the response, the robust response that people have, the antibody response over time. So lots of different inputs into our future thinking, but this is an important area of research.
Thank you so much, Maria. Mike, maybe you can take the next one, because some of our viewers are asking about treatment of COVID patients. So maybe if you can remind us on how patients with COVID can be treated. It depends obviously on the stage of the disease, but some main protocol.
Yeah, well, again, just to reiterate that the vast majority of COVID cases are mild, self-limiting disease. People feel awful for a few days, but in general, people get sick, recover, but for a small proportion of people, that disease can be severe, particularly if people have underlying conditions. And the disease can manifest itself in a number of ways in terms of people needing supportive care, but particularly with respiratory or cardiovascular impacts. And we've all seen it on TV, the ventilators on oxygen, and in effect, patients who have severe COVID and particularly respiratory problems, they need a lot of support. It's not just drugs. People are looking for drugs to treat the disease, but a lot of the care is in maintaining the person's fluids, having access to high-flow medical oxygen, having access to ventilation if needed, so getting the person through the infection. We also have corticosteroids, or dexamethasone, people have heard of, which are essentially very strong anti-inflammatories, and they stop the inflammation process in the lung and allow the oxygen to pass from the air into the blood more efficiently. Again, getting the person over the bad patch. So a lot of these systems are supportive systems. There are then different therapies, monoclonal antibodies, basically antibodies that are grown up from samples of people who've recovered, that you can give to people that mop up the virus in effect, and they give, again, they come in and support the person. The person's generating their own immune response, and you give someone one of these monoclonal, polyclonal antibodies, and it can just help the person developing their own immune response, but it mops up the virus while that's happening, and the person can then move into recovery. And now there are some newer drugs, and I think most of these drugs up to now have been infusions. You have to have them IV. and you have to have them in a hospital, and they're generally reserved for very severe patients. I mean, if you're in an intensive care ward, you can be ventilated, you can get corticosteroids, you can have some of these monoclonal, polyclonal antibodies, interleukin-6 inhibitors, and all of these complex drugs. But we are seeing now newer drugs come on stream, potentially with some prospects that may be used orally and could be used in the event of not milder disease, but in the earlier phase of disease, particularly in people more likely to develop severe disease. So in other words, intervening in an earlier stage with people with underlying conditions. And those drugs show some good prospects. So in other words, interrupting the virus's capacity to make that vulnerable person very sick by helping to kill the virus early in the course of the disease. And there are some promising results coming out for those types of drugs. But again, we remain to see the data. There's been some preliminary data published for one of those drugs, and it's interesting, but again, until we see the actual data and until we see what the actual impact is in the real world, we will wait and see. But it's great to see these molecules coming along now that might be useful earlier in the course of the disease. But we just need to remain cautious, cautiously optimistic, I think.
Cautiously optimistic. Thank you. I mean, you mentioned we started how many deaths we faced so far, but also that almost 250 million of people have been infected again that we know of. So here is a question from Twitter viewer. When does a pandemic turn into an endemic? And will COVID-19 become one? And if yes, how that will be announced?
Yeah, Maria can have a go at this one after me, because I think if you go to the Greek, pandemic comes from the Greek pandemos. Demos means the people and pan means everyone. So pandemos is pandemic, everybody is affected. And right now we're still at that point where everyone's still deeply affected by this and still at risk from disease. A pandemic doesn't necessarily turn into an endemic. Means that the disease is circulating at a lower rate and more predictable rate in the population. So we would see certain viruses settle down into an endemic pattern over time. It's usually maybe some seasonal pattern of disease. And then you see some diseases that will have an endemic pattern, low level of disease, and then occasional epidemics. And clusters or hotspots of disease. And I suspect that's what's going to happen with this pandemic, is that we're going to see, as we're seeing now, the death rates have dropped, hospitalization rates have dropped, and even case incidence rates are dropping in some countries, but there are still flare-ups in areas of low vaccine coverage, and we're going to see, I think, increasingly a bumpy road. It's like a bumpy landing, you know. We'll come in from a very high place and we bounce on the runway and we bounce again and then we bounce, and maybe the bounces will get smaller and smaller, but there's going to be a lot of instability. So the idea that we're going to switch from a pandemic to a low level of disease overnight is not going to happen. And disease being endemic doesn't necessarily make that a bad thing, because what it means is, number one, we're on top. If we have enough people vaccinated, the disease remains mild in younger persons, and we don't have the emergence of new variants, then we will have a disease. I don't think at this point in time, given the vaccines we have, and given the way the virus changes, that we will eradicate this virus. This is not like polio or smallpox, at least for now, until we have much better vaccines at the very least. So I think we are going to be living with COVID, with SARS-CoV-2 for a very long time. But that doesn't mean that the virus has to continue to disrupt our lives. And I'll give you an example. We had a pandemic in 2009 with H1N1 virus. This was the influenza virus. And that virus was a brand new virus, spread around the world. in 3 months, 6 months, went in a number of waves. It was very mild, but it had a very similar pattern to what has happened with this pandemic, but a very mild version of the disease. That virus has never disappeared. That's still the predominant virus. 11 years, 12 years later, that's still the seasonal virus. So it went from being the pandemic to being this seasonal epidemic. And we may see COVID-19 or SARS-CoV-2 infection go from being pandemic to being seasonally epidemic or to being low-level endemic. And we also see that with influenza. It depends on what part of the world you're in. If you're in the north, the cold countries of the north or the southern hemisphere, you tend to have zero influenza and then you have a winter epidemic. But there are other parts of the world where there's no real pattern. It's kind of in the tropics, it's kind of endemic. It's happening at a low level all the time. So I think it will depend on where you are in the world. But the idea that the pandemic shifts to become an endemic overnight and there's some machine that's going to give us an answer to say, yes, it's now it's no longer a pandemic, it's an endemic. There is no calculation, there is no algorithm for that. And I think it's a judgment, and it's a somewhat subjective judgment because it's not just about the number of cases. It's about severity and it's about impact. So therefore, we're just going to have to keep tracking the virulence of the disease, how many hospitalizations, deaths it's causing. Because even if the disease were to reduce the number of cases significantly, if a new strain of the virus was to emerge that was more virulent, then we'd be back to square one.
Yeah, I mean, I agree with everything Mike just said. I think we get this question a lot of like, when will there be this switch from a pandemic to an endemic, and it just doesn't work that way. I mean, it'll be a slow change, but pandemics end. I mean, we can say that pandemics end, and this pandemic will end. How fast we get there is up to us. It's always been up to us. But I just want to, I'm uncomfortable with how some are using the word endemic. I think there are real legitimate questions about what's happening with this virus and what's the future of COVID-19, but I'm very uncomfortable with the way some are using endemic and saying that once the virus becomes endemic, we're done. It means that we just live with it where there's nothing more that we can do. We are not there. Endemic does not mean that it's not dangerous. Endemic does not mean that we give up. Endemic has a meaning about a low-level circulation. It also has a geographic area. It won't be transmitting at this level of intensity. And what we are seeing, the future of COVID-19, is that we will continue to see outbreaks among susceptible populations. We will continue, whether we have a seasonal pattern, that remains to be seen. It's a respiratory virus, so we expect that, where we have changes in people's behavior, of how they spend their time indoors and outdoors. So we expect there to be some seasonality, but don't be fooled by that. Right now, we are very much in the middle of a pandemic. And I'm uncomfortable with the use of this phrase that it's endemic, it's over. Or it's endemic for us and it's a pandemic over there. That is not true.
That's the one
It's just absolutely false that it could be endemic somewhere and a pandemic somewhere else. And quite frankly, this pandemic began that way, where it was a problem over there and it's not a problem over here. That is not how this virus works. And I think for us, the big wild card are these variants. So if we only focus on vaccination, which is an incredibly powerful tool, if we only focus on vaccination, we allow the virus to continue to spread, and we will have more variants. If we have variants that render our countermeasures ineffective, we essentially start over, and nobody wants to be in that position. The likelihood of that is quite low, but it can happen. And we just need to be careful about how we talk about this, because you cannot have an endemic somewhere and a pandemic elsewhere. We are very much in the middle of this pandemic, and we can't use these words to pretend that the virus is over or that the pandemic is over for some and not for others.
Yeah, and it's interesting, you'd say that multi-resistant tuberculosis is endemic in some countries. A lot of people die from it. It's a very, multi-resistant Staph aureus, MRSA infections. Many of you out there will know people in hospital who've got those very severe infections. Hospital-acquired infections are endemic, but they kill a lot of people. So saying something is endemic doesn't mean that it's mild. It doesn't mean endemic is more about the pattern of the disease, not about its severity or its impact. And an endemic pattern means it's kind of here to stay. And it's endemic. It's with us forever. That's what endemic sort of means. But you know, endemic and with us forever, where we have people not vaccinated and people having to go onto ventilators and ICUs full. That's not good endemic. You know, I'd like this disease to become a mild disease that may be endemic, for which we have high levels of vaccination and we have good therapies and we have available clinical services for people with underlying conditions so they can get oxygen when they need it or get drugs or get whatever they need, so that we take the death and we take the hospital. We spoke about the deaths earlier. You know, we need to take the death out of this pandemic. So if you take the death out of the pandemic and take the hospitalizations out of the pandemic and take the ventilators out of the pandemic, then I'll be happy to call it endemic. But the idea that we want to move to calling it an endemic because we want to declare victory and we want to say it's all over. I even heard someone the other day saying each country should decide whether the disease is a pandemic or not. I mean, what a fallacy, because pandemic means, you know, it's affecting the whole world. No one country can decide that the pandemic is over. It beggars belief. But it is important. I think, Maria, your point is absolutely correct. It's really important now that we don't have a weaponization of these terms and names, and that we focus on our problem. Our problem is too many people are getting sick, too many people are dying, and we can prevent a huge amount of that by vaccination, by equitable distribution of vaccine, by preventing infections where we can, and by ensuring that people have access to high quality clinical care when they do get sick. That's what we should be looking at, and not having intellectual arguments over whether something meets a definition of pandemic, epidemic, endemic, so that we can then say, well, it's endemic now, so that's it. Let's throw all caution to the wind. We're not at that stage yet.
Thank you both, and we started with how much everyone has been impacted by the pandemic, but probably the most are the health and frontline workers. So maybe we can end on that note. And here's a great comment from Veronica Douglas. It's not a question, it's actually just a comment. Globally, let us all show solidarity to stop transmission of COVID-19. Healthcare providers are tired, exhausted, and are suffering from burnout syndrome. So thank you, Veronica. This is a great great comment and way for us to end it. But maybe I'll add a question just to remind again everyone. I know we've been repeating this all the time, but it doesn't hurt repeating once again what we can all do to protect ourselves and therefore to help and express solidarity for health care and frontline workers.
There's so much we could do, but maybe I could just mention I did this really wonderful event this morning with the International Council of Nurses, and I was invited to be part of a panel in one of their plenary sessions, and it was such an honor to be part of that. And Annette Kennedy from the International Council of Nurses was there, and so was Howard Ketton, and we've been working with them for more than 70 years, in fact. But it was just a nice opportunity to thank nurses and thank health workers, you know, around the world for what they do. You know, all of us at an individual level, the best thing that we can do is to keep ourselves safe and our loved ones safe so that we prevent infections in the first place and not need that care. But we can offer support to health workers. Health workers are people, they're families. You know, they have families, they live in societies. They should be respected. They need to be cared for. They need to be trained. They need to have proper personal protective equipment. They need to not face stigma. They need support with mental health because the burden on health workers around the world is, I think it's just beyond, it's incalculable. But their contribution to this pandemic and beyond is incalculable. And we owe them so much. So I did want to just say thank you to the International Council of Nurses for the invitation. The DG will be speaking at that event later this week. But so for us, you know, it's important that you get vaccinated when you can, when it's your turn, get vaccinated, but also practice individual level measures. Wear a mask, Make sure it's a well-fitting mask over your nose and mouth. Make sure you have clean hands when you put that mask on and take that mask off and dispose of it properly. Keep your distance. Physical distancing remains critically important. Make sure you spend more time outdoors than indoors if you can, and if you're indoors, make sure it's in a well-ventilated room. We need our buildings where we live and work and go to school and study to be well-ventilated, so investments in ventilation continues to be important. But all of these measures, avoid crowded spaces, are really important. And for societies, for governments to invest in public health, invest in surveillance, invest in testing, and so that tests can come back rapidly so that people know what to do, and that we support early clinical care by trained, protected, and respected health workers to make sure that we keep advancing R&D. There's so much that all of us can do, and I think anyone watching, whatever your role is, however old you are, do something that contributes to ending this pandemic, whether it's sharing good information or just offering, a listening ear to someone and reaching out, because all of us are suffering from this, and our mental health needs to be addressed as well. So it's a long answer because there's a lot that we can do, and I want people to, especially following that last question about endemicity and pandemic, there's a lot we can do. This virus still has control over us, but we can gain control over this virus. We can take the death and severity out of COVID-19, but we can also limit the spread. And I think that comprehensive sort of Swiss cheese approach, layered approach, is what we've been advising from the start, and we continue to enforce that as much as we can.
Yeah, the spare thought for those health workers. I've been in contact with some of my colleagues in Ireland over the last couple of weeks, and I think they're really staring into an abyss in many countries now because, vaccination rates are very high, population are done a great job, rollout vaccines have been excellent, but hospital beds are filling up again, the ICUs are filling up again, and I think there's just a real sense of panic and fear that here we go again, and elective surgery is starting to be cancelled. This is across Europe, you see it. Elective surgery is being cancelled, the emergency rooms are full. People are worried about people in long-term care. We're back, in a sense, we're not where we were 18 months ago with the vaccines, as Maria said, very high levels of protection. But with the intense transmission we're seeing, particularly, I'm saying Europe, not because we're in Europe, just because that's where the numbers have increased so much. If you really want those health workers to get through this next 4 or 5 months, everyone's become a COVID expert. Everyone knows about the lag time. Transmission today is hospitalizations next week, and it's people in ventilators the week after, and it's people, unfortunately, in coffins the week after that. That's how it works. So keeping the number of infections down to the absolute minimum by just doing the things to protect yourself and others. And it's not to stop people. People have to go to school. People have, we realize that, and especially with vaccination, it offers us that opportunity. But if you're vaccinated, you still need to take some precautions. Yes. You still need to look after yourself and look after others and be protected by that vaccine. And if you're not vaccinated, please, especially if you're a vulnerable person, underlying condition, if you're an older person, get vaccinated. And if you're a family of an older person or someone with an underlying condition, please, because that is the best thing you can do right now to protect health workers in 6 or 8 or 10 weeks' time, is to make sure that everyone who's potentially going to end up in an intensive care unit in 6 weeks' time is vaccinated now. And unfortunately, in many countries, that opportunity still isn't there yet because of the awful vaccine inequity. But there are countries, for example, many countries, who have high rates of vaccination, but there are groups within the country, marginalized groups, migrants, ethnic groups, social groups, who are not fully vaccinated. And there's issues of vaccine access, accessibility, vaccine hesitancy, and many other things. So we need to redouble our efforts, because certainly I've seen in the eyes of many of my colleagues that 2-year fatigue, really, and almost a sense of terror at the thought of having to go through this again. And these are tough people. A lot of my colleagues have been at it for a lot of years, and they're really, there's a lot of fear and trepidation. Are we going to be able to get through this one more time, because there's also a sense that the system is weaker than it was before. Been through these 3 waves, you know, and people don't feel that the system is any stronger than it was before. A lot of health workers in some countries are leaving the profession as well. That's been a big problem. So less people to do the work. So, you know, protect yourself, protect your loved ones, but protect our health workers by making sure we keep transmission to the absolute minimum. And please, 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 please get vaccinated.
Thank you, Mike. Thank you, Maria. Thank you, Veronica, for this great comment to end today's conversation. I thank everyone who's been watching us. There's a long list of countries, but stay safe and keep following us for any updated information, and talk to you next week. Goodbye.